So this is day one of the live event on how I'm going to show you how to be the go-to CT tech. So I'm just going to go over some points. This is going to be 3 short trainings. I'll probably try to make it 20 minutes or less, not to occupy everybody's time. So I am doing this one live for today. The day 2 and day 3 are going to be pre-recorded because unfortunately my grandmother passed away. And I have to travel starting tonight so I can have all the stuff for the funeral arrangements and things like that. So we're going to dive into day 1. So we're going to talk about 3 things that I feel are important, especially when you're a CT technologist, whether you're new, you're 3 years in, you're seasoned, doesn't matter. So if you don't know who I am, my name is Karina Hogan. I am a registered radiologic technologist. I'm also a registered CT technologist. I do have my bachelor's degree in radiological sciences and about 3 classes away from my master's. So I do have a lot of CT experience. I have 21 years in the business, been in radiology 23 years altogether. I currently work in a trauma hospital on the south side of Chicago. And I am the mom of 3 daughters. So 2 of them are special needs, and I'm very knowledgeable in all 4 of the most popular CT systems out there. I know there's others that exist, but as far as every hospital that I've walked into, that is my expertise. Now, the topics for today. So typically what I do in my trainings is I'll do a little bit of slides and then I go ahead and I teach. I don't like to do a lot of slide presentations because sometimes people are more visual and they like to listen. So topics for today, we're going to talk about patient centering and positioning, why this is important, what not to do, and the consequences of patient centering, of improper patient centering. This is a big topic, and I know I talked about this on my podcast. Also, communication and patient care, patient education during the exam and after, and collaboration when it comes to radiologists, physicians, nurses, you name it. So let's talk about patient centering and positioning. Talk about ISO center. So here's some key points that I want you to remember. Patient centering is necessary. Please do not guess, do not eyeball. It's going to throw off your dose and the quality of your images are going to be complete crap. Okay. Use the laser light. It is there for a purpose. So make sure you use your laser light. If the laser light is not working, make sure you get service to make sure that they do work. Also, you increase the dose when your centering is off, okay? The dose needs to stay within ACR guidelines. Now, there are some exceptions to the rule though, okay? The exception is that sometimes we get patients that are not ideal, they're contracted, they have a lot of body habitus as far as adipose tissue. Some patients are very large. What I say to that is just make sure you do the best you can and try to center them as properly as you can and try to immobilize in table straps. Sometimes that does help to offset some of that extra scatter, okay? I'm going to show you a typical scout of what proper patient centering is. Now, this is a abdomen and pelvis scout. So this is a lateral scout, okay? And you can tell by the green check mark that this technologist used their laser light and the patient is centered correctly. So when the system calculates, it's going to calculate the dose correctly, right? So you have to make sure that when you're centering the patients, use the laser light. I cannot stress this enough because there's a lot of technologists out there that will just eyeball it and the numbers are crazy high. And on top of that, we have a physicist that's very freaking picky at our facility. And it's for the chain of hospitals that I work at. You don't want that, okay? So you want to make sure that your patient centering is just on point, okay? Like I said, there are exceptions to the rule. Now I'm going to stop sharing my screen, okay? Now, I am going to talk to some points when it comes to communication. So when I'm talking about communication, when it comes to patients, communication is that we have to explain to them in layman's terms. So educate them on what's going on with the exam, how long it's going to take, what they're going to feel when they get contrast media injected, or if they have to drink barium, or if they have to drink Omnipaque, they have to drink gastrografin. So explanation goes a long way when it comes to making sure that the patients know exactly what is happening before, during, and after a CT scan. Okay. It's also very important to communicate with nurses and with the physicians and with the radiologists, because if an order doesn't look right, we have to question it, right? If the test that they're ordering isn't really related to the patient's problem, we question that, right? So it's always good to have great communication, because then you can save the patient an exam, or they can have let's say it wasn't a CT that they really needed, it was really an ultrasound, you can save the patient the radiation dose, right? So those are some of the things that are super important when it comes to communication. I'm going to give you a script on what I do when it comes to talking to patients and just walking through the exam. So here's an example. Hi, Mrs. Jones, I'm Karina. I am your CT technologist. I am going to perform a CT abdomen pelvis with IV contrast. Did you drink the oral barium that we gave you? Yes. Okay. So now, have you ever had contrast dye? Because you have to explain it to them in layman's terms, right? So if you say contrast media, most patients are not going to know what that is. Usually I say it's a form of X-ray dye that we're going to inject in your body. It's going to make you feel warm from head to toe, might get a metallic taste, might feel like you're wet in your pants, but you're really not. But those are some of the side effects that you will feel. And usually they'll say, oh, is there an allergy to it? If you're allergic, then this is what will happen. And you explain that to the patient. You'll get hives. If you get any itchy eyes, if there's any vomiting, if there's any throat closing, any chest pain, those are things that have to be communicated to the patient. And usually I'll tell them, okay, this is how you're going to lie down. Your head's going to go here. Your feet are going to go in the machine. You're going to put your arms above your head if you can. And the machine's going to ask you to hold your breath. Do the best you can. And then usually I'll say, do you have any questions? And then I pause, because I want the patient to let me know if there's something that I didn't answer for them. Because I think sometimes we rush through the process with communicating with the patient, and then it's, oh, I didn't understand that exam, because we use a lot of medical jargon that the patients don't understand. And especially in radiology, we do. And especially in CT, there is a lot. Okay. So what's critically important is to make sure that we explain it in terms that they can understand, and to make sure they understand what is happening during, before, during, and after the scan, right? So also, after the exam, I always ask them, everything okay? Are you feeling okay? Just to make sure that the patient is good, okay? And then I always ask if there's any follow-up questions that they want to ask me. Pretty simple, right? Now, when it comes to physicians and radiologists, we always communicate with radiologists for protocols. Like if something feels off and they want, I'm going to just throw a generic one out there that's just really ridiculous. Oh, they want a head CT because he has toe pain. Okay, now I'm pretty sure we've all seen that. But of course, if it's something that's outlandish where you're like, okay, this order doesn't make sense, and it's good to have good communication with the radiologist. I know not all radiologists are very friendly, because some of them are just really angry that you're calling them. However, it's always good to collaborate and make sure you're on the same page, because you're questioning something that doesn't make sense, because they're going to be reading it, right? So it's always good to make sure that is happening. Okay. Also, communication with physicians, because we all know that physicians do not order everything correctly. And especially since we have new residents, they're not going to order everything correctly. So it's our job as the technologist to make sure that those orders are correct, because what we want to eliminate is extra radiation to the patient, right? We want to eliminate, oh, Mrs. Jones got 5 different CTs when she only needed 1, or maybe she didn't need any, right? Communication and questioning when the order doesn't make sense is always a good thing, okay? Communication with nurses. We need specific IVs when it comes to specific tests. Now, not all patients are ideal. Don't get me wrong. It's not like I've never done a PE study on a 20 gauge in the wrist, okay? It's because patients are critical. Patients don't have any veins anywhere else. They've got AV fistulas. If they don't have any veins, they're IV drug users. There's so many things that can happen. What I can say to that is use your best judgment, okay? Use your best judgment, because you are the one performing the exam. Use your best judgment and make that call if you're going to use that IV or not. okay? Because not all patients are ideal. So that's what I tell all the technologists I train, use your best judgment. If you feel, hey, okay, I can do it, great. If not, call the nurse. And I know nurses can be a little testy, okay? And they can give you grief, and a lot of them will give you shit because of that IV was good and it actually isn't. And I think the breakdown in communication is that they don't understand when we power inject, we're executing a lot of force into a vein because contrast is very viscous. In contrast, especially since they've joint commission and all those regulatory agencies have taken away warmers because you have to check them properly, or you can't have them at a site, because I know we're not allowed to have them at our site. So it makes it very challenging because to explain, okay, we're injecting at this high rate, we have to be able to have good access to make sure that it's safe to inject contrast. And just a little communication goes a long way. Like, we're all in this together as a team and we're all here for the patient, right? So good collaboration is always good, because I know we partner up with the ER. The ER at my hospital is like right down the hall. If you turn from the corner from CT, like, the ER is right there. Okay. So we're always in constant communication and collaboration because they are so close and patients are in and out of that department consistently. So the last thing that I'm going to bring up is collaboration is so important, whether it's a nurse, physician, a resident, the patient's family, whatever the case is. Good collaboration is good because we're there for the patient, and the more information that we know, the better the outcome, right? So we always have to know that, hey, this is how we're operating this. This is how we're doing this. This is what we're going to do. We need to know more clinical information on the patient. Okay, this patient came in as a trauma. What would you like scanned before the patient comes over so they can throw in all the orders, right? So a lot of checks and balances go into us being the go-to CT tech. Like, we deal with the most complex exams all the time, and we constantly have to talk to different groups of people. So it's always good to have a very positive collaborative team. It's not always going to be that way, okay? Because there's just going to be some that are freaking grouchy, and if you ask them questions, they don't want to give you any answers. And that's totally okay, okay? Because there's other ways to get information, whether it's looking in the patient's chart, whether it's asking family if they're around, whatever the case is, right? So those are the 3 points that I wanted to hit as far as what is important when it's in our role as far as a CT tech. Like, patient centering, I can't get enough of it, guys. You guys have to make sure that your centering is perfect, okay? Not really perfect, but it's on point. Like, to make sure, because it's super important, because if you want an optimal scan and you want that optimal exam to make sure that they can clinically diagnose the patient, you got to do this patient centering, okay? Also, communication, patient care. Make sure your patients are safe on the table. Make sure you utilize your safety straps, pillows, blankets, anything that's going to make the patient comfortable while they're there for the 5 minutes that they spend with us. Make sure you do it. Try to go above and beyond for the patient. Now, I know we all encounter patients that are grouchy, patients that don't want to be bothered, patients that are altered. You know what? We handle every situation with care. So make sure that as far as patient care, you execute that, because the last thing you want is movement on your scan and you have to repeat something, because every time you repeat a CT, the dose goes up double, okay? So you don't want to do that. You want to make sure that the patient's comfortable, making sure that you review everything, making sure that labs, IV, allergies, all that. And if you have allergy protocols, which everybody does, okay, make sure you follow those as well, okay? And then also, collaboration is super important, okay? Especially the new residents. If you haven't listened to my podcast episode about the July effect, those new residents are learning. It's good to communicate with them. Show them, okay, this is why we need X, Y, and Z, because a lot of them are brand new coming in. They're not aware. And it's our job to collaborate with them and actually teach them something sometimes, okay? So it's very important to have good collaboration, have good communication with nurses, with physicians, with the radiologists. Even though they all may be cranky, who cares, right? So those are the 3 points that I think is a good starter as far as when you go in, just make sure that as a CT tech, you do that. Make sure that you also know your protocols on your scanner. Not saying you need to know all of them and keep them in your brain, but there are common ones that you do every single day. Make sure that even if it's just okay, I'm going to hit this one, we're going to do this. Like me, I'm a perfectionist. So I'm like, okay, I'm trying to perfect this, but make sure you're knowledgeable and keep educating yourself as far as making sure you're staying in the know of what is going on, because protocols change all the time. So make sure you do that and stay within the trends and the latest and greatest when it comes to CT. Okay. We know AI is playing a big role in our imaging department. There's a lot of AI integrations going on. I know we use AI when it comes to strokes, and they have integrated a third party that has a program. So we don't have to do perfusion maps anymore. It makes our workflow very easy. That's another point, the workflow. Make sure you know it. Make sure that your workflow like works for you in your department. Make sure that, okay, the way you set up your exam is probably not the way I'm going to set up my exam. Like techs have different types of knowledge and different ways on how they execute things, but they still get the same result. So my takeaway on that is make sure you learn from everybody, because everybody has different experience, and you can take a little piece of everything that you've learned from a different person and apply it to your skill set and how you execute your exams. Okay. So I hope this was very helpful. So in day 2 tomorrow, I'm going to go ahead and talk about a couple of more topics. I'm going to talk into depth about contrast media. And then on day 3, we're going to go into some exam protocols and some things that I feel are necessary when it comes to making sure that you execute it correctly, and just some proper setup when it comes to that. So tomorrow I'm going to talk about contrast media and IV gauges, because I think those are important to know. And then on day 3, I am going to talk about exam protocols and just a few things that you can do to really set them up really good. So hope this was really helpful. So can't wait to see you guys tomorrow. So take care. Hello, welcome back to day 2. So in today's lesson, I know it's a little late. Yeah, because I am traveling. So in today's lesson, so we're going to talk about contrast media and IV access. So that is going to be the main focus for day 2 of the live event. So I'm going to go ahead and share my screen. I did got together some PowerPoint slides. So this one, I don't like to make things slide heavy, but I figured since visuals are really good, and I'm a very visual person, and as CT techs, we're very visual. So I will have the PowerPoint slides as soon as this video drops in the Facebook group. So there will be a PDF download also with IV access. Once we get into that part of the lesson for today, there is going to be a PDF download also for IV gauges and the flow rates for that. So you'll have 2 PDFs in the Facebook group. So let me share my screen. All right. Okay, so we're on day 2 of the live challenge. So we're going to be talking about contrast media, IV access, and flow rates. So the topics that I'm going to cover in day 2 are contrast media, the types, method, any special considerations that we have with contrast media, IV access, what is used, what should not be used, and what is not injectable for CT. Flow rates. So we have different exams that require contrast that we use various flow rates for. Now, if you are a new tech, you're probably wondering why we use contrast media. If you're more seasoned, you know why we use contrast media. So contrast media is used to distinguish the different densities and increases the visibility of anatomical structures and pathology. So roughly about 80% of CT imaging is always ordered with contrast, because we know we get a lot of it. So I put together some common exams that require contrast, your PE study, your AAA dissection, runoff, angiography studies, any head imaging, your typical abdomen and pelvis. And in CT, positive and negative contrast agents are used. So I'm going to go into that in just a little bit. Now, the different methods of contrast media that we do is we do intravenous, so the vein, intravascular, arthrogram studies, oral contrast, rectal contrast, intrathecal with myelograms. So there's many methods on how we administer contrast media to patients. Now, for oral consumption, I've listed two pictures here. So our standard when we scan outpatients is usually our ready cat. Or if we do have an inpatient that might be allergic to contrast media, IV contrast media, typically we'll give them the barium sulfate because it's upon the patient request. Even though I have had patients consume oral contrast, whether it's Omnipaque, Gastrografin. However, sometimes it's more of a comfort factor for the patient, so the ready cat is always available for them. So I know some institutions, they do use Gastrografin, they don't because Gastrografin is an ionic type of contrast, or they will use Omnipaque 350 for oral consumption. I know I worked at one hospital where they did use IceView. I know the FDA has approved Omnipaque for oral consumption. And I believe IceView is the same principle. So these are the types of IV contrast we use, like I was just explaining. So there's Omnipaque 300, 350, there's IceView 370, there's also Visipaque 320, which Visipaque is something that we use with patients who are renally compromised, dialysis patients, any patients that have low GFRs. Visipaque is a good alternate to that because what it does, it'll highlight the vessels and then it starts to dissipate, not like Omnipaque where it sticks around. So these are the concentrations that we use. I know at my facility, we use 300 for typical routine studies and pediatrics, and then 350 for all the angiography studies, PE studies that need nice enhancement. Now, the negative contrast agents, so the prior to those are positive contrast agents. So your negative contrast agent would be water, of course, air. When we do CT colonography, water when we do any type of gastric or pancreatic studies because you want to be able to separate. And we also use something called volumen. I know there's another name out there. I can never pronounce it. So this is more of a negative contrast agent because it's more of a watery base and there's very little barium sulfate on here. It's like a watery concentration. So these are good for bowel studies when it comes to the small bowel with like irritable bowel syndrome, Crohn's, things like that. So they want to see the walls of the small intestine. Now, it's very important that we screen our CT patients thoroughly. So what I mean by screening is patient history, list of allergies, lab values, any prior exams with contrast, anything that would require us to make sure that we're doing the correct exam, anything to make sure that it's safe to give IV contrast to the patient. Also with reviewing their meds. So making sure that they didn't have any prior contrast reactions or they don't have a list of allergies of 10 or more, because that can really come into a play and it can be a contradiction, especially if we're going to give IV contrast. And explanation of the exam, the side effects, the after effects, anything that can be communicated to the patient and verbalize that with their understanding and make sure that you explain to the patients in terms that they can understand. Because we all know that the medical jargon, a lot of patients do not understand that. And a lot of patients are unconscious or they're altered. So we have to either explain to a family member or there is always like the informed consent as far as administering contrast. Now, lab values are very, important and they are needed before any contrast media study. So the typical ones are creatinine and GFR. I know BUN, some facilities still use that. I know ours, we don't really look at BUN. We look at either the creatinine or the GFR. So anything below 30 is not safe to inject contrast. Now, that could vary from facility to facility unless it's approved by a radiologist or an ordering physician. So I would always check your policy and procedures to make sure that you have the standard of what you can't go beyond. Now, diabetic patients, as far as special considerations. So patients taking metformin, the brand name glucophage, should stop this medication 48 hours after a contrast media exam. So they need to make sure that after we're done with the test, they don't take any metformin for 48 hours. Now, some facilities have done away with this practice. Some still do it. It really depends on where you work. The reason we do this is because we want to make sure that the kidneys are still functioning properly and not compromised by IV contrast use. So the patient should get their labs checked again, just to make sure that their kidneys are functioning properly. Now, dialysis in renal compromised patients. So dialysis patients can have IV contrast and have an exam if their dialysis occurs within 24 to 48 hours. Okay, and usually that is approved by a nephrologist and they will give the go-ahead. Now, contrast media is at the discretion of the patient's physician or nephrologist. Okay, so that is usually where we get our direction. Or usually with outpatients, they will tell you the schedule on when they get their next dialysis. And usually they are scheduled 24 hours before. Now, patients who are renally compromised, let's say they have a low GFR, they're not on dialysis or anything like that, sometimes can be instructed to hydrate before and after a contrast exam to make sure. And sometimes they will be given medications, something called mucimist, to protect the kidneys. Now, with dialysis patients, they are 9 times out of 10 on fluid restrictions. So they cannot hydrate like a normal person because their body already accumulates enough fluid. And so when they go for dialysis, they take off the fluid. So you have to be mindful when it comes to that. Okay, so pregnant patients and breastfeeding. Now, the benefits should always outweigh the risk and clinically necessary when we're doing exams with contrast on pregnant patients, okay? Customarily, patient consent and documentation from the ordering physician should always be done, okay? The patient should understand all the risks involved and be okay and sign off on the consent. Now, there is no hardcore evidence, or it's unknown to the fetus if there's any risk or long-term effects as far as going ahead with the CT and IV contrast media, but caution should always be considered because we don't know if contrast media is going to affect the fetus because there's not really a lot of clinical documentation out there or hardcore evidence to sustain that. Now, nursing mothers can be instructed to pump and discard breast milk 24 hours after a contrast media exam to minimize the risk. Now, I know at my facility, we don't do this anymore. We have stopped doing it because the radiologists have confirmed that there's really no evidence saying that it's harmful, but it could be at the discretion of the mom. We can give them a recommendation to do it if they choose to. Now, allergies. Now, patients with a prior reaction are at a very high chance of developing another contrast reaction and should utilize a pre-medication protocol, okay? 9 times out of 10, when we see contrast allergies and reactions to contrast, it's usually patients who have had contrast before or have a long list of allergies. Now, it is not uncommon for a patient to get a contrast media injection for the very first time and be allergic because it has happened. But 9 times out of 10 is usually the patients that have had contrast reactions in the past, and then they have it again. All CT departments should have a pre-medication protocol. There should be an emergency prep and a non-emergent prep, okay? And this is by ACR guidelines. Also, ordering physicians should consult the radiologist for proper pre-medication protocol because we get all of our recommendations from ACR and they list out how the patient should be pre-medicated. Now, when you get a contrast extravasation, this is exactly what it looks like, okay? So on the left, that is contrast pulled into the arm because the IV is no longer in the vein. And then on the one on the right, this is what it will look like, you know, um, when contrast is infiltrated in the skin. So always check your IV, always, always. Now we're going to move into the section on IV access, so catheter size and various types. So typically IV catheters range from a 14 gauge to a 24. So each size is associated with color to determine what gauge it is. So the smaller the number, the larger the gauge is going to be. The higher the number, the smaller the gauge is going to be. Okay. So usually 14 to 16 gauge, if I remember, I know a 16 gauge is gray. So it's a big, large bore IV. Perfect for PE studies. Love them. 18 gauge, of course, is green, 20 gauge is pink, 22 is blue, and 24 gauge is yellow. So typically in CT, we use between an 18 gauge to 22. So 22 gauges usually is for more routine studies. If patients have bad veins, things like that, we can typically use a 22 gauge for a head with contrast, an abdomen and pelvis, something that's routinely done that's not an angiography study. Now, pediatric patients, since they are small, their veins are hard to find, 24 gauge is sometimes what they will use. Now, if they are going to use a 24 gauge, a hand injection is required. You should do a hand injection, okay? Unless they have a 22, they're a bigger kid, okay, you can power inject it probably like a 1.5. But 24 gauges, hand injection, because usually it's on a small little kid, little baby. You don't need a lot of contrast and you can hand push it. Now, we always have to remember contrast is very viscous. That's why we always tell the nursing staff we need an 18 or a 20 gauge because that is the preferred method of access because we're pushing at such a high force. We're pushing at 300 PSI, so it's a lot of force going into that vein so we can push contrast through the bloodstream. Now, these are some pictures of the type of IVs that I use at the facility I work at. They range from 18 to 24, so if you can see all the colors on both pictures. Now, the last picture is what we call a 22 diffusix. It's a 22 gauge, but we can inject up to 6.5 cc's per second at 325 PSI. So let's say they can't get a 20 in the patient, they'll use a diffusix because usually they're good for patients who are hard sticks. And I'm telling you, it's a beautiful IV. Like I use them all the time for PE studies. It's great. So that is a good alternate. I believe the manufacturer is Braun who supplies these, if I'm 100% correct. Now, you're also going to have other forms of IV access. So what I mean by other forms is that we have PICC lines. So they're purple and most of them are power injectable because they'll say on the hub. We have central lines that are usually either in the neck or they are in the groin. So most of the central lines that are made by Cook or by the other manufacturers, they are power injectable because the hubs will say 5 cc's, 10 cc's. It'll say something on the hub. Power ports. So they're injectable ports in the patient's chest. A lot of them will be triangular shape. Some of them will say CT in the middle. So we always have to check and make sure that it's a power port that we're injecting. And always verify those lines to make sure they're power injectable before you use them. Now, I'm going to talk about the IV access that you absolutely should not use in CT, okay? EJs, external jugulars. This can compromise the patient's airway. I don't care if a doctor says it's fine. It is not fine to power inject. We're talking about an external jugular. It can compromise the patient's airway where you have an IV in the neck, okay? It is not to be used for power injection, okay? Hickmans, Cordis, Swans, these are sheaths. They are not something that is inside. It's going into a vein. However, it's still an open access. So that's why they are temporary access. Like a cordis is for trauma, where they go ahead and need to just shove a bunch of fluids and a bunch of meds into the patient like quickly. These are not power injectable. The rate of PSI for any of these is 45 PSI. Remember, we inject contrast at 300 PSI. Absolutely not, okay? A Broviac, which is something that is used on pediatric patients, which is similar to a Cordis and a Hickman. These are absolutely not rated for power injection. Do not use them. Please do not use any of these types because you can compromise the patient airway and it could be very deadly. I can tell you, a Broviac was used at my facility and they had to take that baby to the OR. So please do not use these accesses because they are not rated by Bayer, who provides us the MedRat injectors. So they are not cleared for power injections. Now, of course, power injectors is very, so I know probably many years ago, we used to have a single head. Now we're more of a dual head power injector where we do the 2 syringes with saline and contrast. One tip I'm going to give you, please make sure that you prime your tubing thoroughly, okay? This should be done to prevent any air embolus. This step is crucial because it's the last step before you hook it up to the patient. So make sure you prime your injector. Now, of course, if you've never seen a power injector, this is typically what you will see. Of course, blue is saline, green is contrast. It was funny because when these injectors came out, I had asked the rep and I said, how do you tell the difference between contrast and saline? And she says, blue is always water, and then contrast, green, patient gets sick, they turn green. I thought it was perfect. Normally before we administer any contrast, we like to do a saline and test injection. So a saline test injection to test the IV to make sure that there's patency, no infiltration to the site. So make sure you hand flush 10 cc's of saline first, make sure you check that line. And then typically you can use 20 to 30 for that saline test at the same rate you would inject contrast. That's very important, okay? I always tell my techs this, make sure if you're going to do a saline test, inject at the same rate you're going to inject contrast. And then we do a saline back flush. So after contrast runs in, we want to make sure we keep that enhancement so that we don't lose contrast enhancement while we're doing our scan. So usually 30 to 50, depending on what you use, is usually sufficient, okay? So what that does, it'll reduce streak artifact, it maintains enhancement, and it also minimizes the contrast-induced neuropathy. So it gives the patient a little bit of hydration. Okay, so flow rates and injection protocols. So we use a bolus injection method. So it's pushed by a power injector into the bloodstream. So AC line, so anticubitals, usually between 4 to 6 mLs per second. We can use a forearm. You could typically use 3 to 4 depending on the position of the forearm. If it's higher up in the AC, you could use 4. If it's mid, maybe 3.5. Use your best judgment. Wrist hands, 1.5 to 2. Pediatric patients, like I said before, hand injections. Usually over the age of 5, you could probably use like a 1, depending on the size. But always use your best judgment. If the IV doesn't feel right, don't use it, okay? Have them start a new line. If it's not comfortable and you're not comfortable and you feel like this might infiltrate, do not use it. All right, so I'm gonna stop sharing my screen. All right, so that is it for day 2 of this live event. I'm super excited to be teaching this. I do apologize that I am traveling. Things just come up unexpected, but you know what? We make it work because that's what we do. So make sure that you guys grab the PDF downloads. So there will be a download for IV access and the different gauges and injection protocols. And then there's also a PDF for the slides, okay? Thank you so much for joining me in day 2, and I will see you tomorrow for day 3. Hello, and welcome to the final day of Be the Go-To CT Tech live event. So this one's going to be a little short one today because I'm getting ready to get on a plane and I still have my children. So got to get them dropped off to their dad's house. So in today's lesson, I am going to be sharing some points on how you can better execute your CT exams and protocols. So I will be going over a common CT protocol with you. And then at the end, there will be a PDF guide of some common CT exams and protocols that you can download and just study off of, or make sure that you review and make sure it's something that you do where you currently work at or something similar. Also, I have opened the doors to my newest coaching and mentorship program. So the CT Educator program, it's a 6-month program where I get you test ready. I get you to elevate your skills as a CT technologist so that you can walk into any facility or take a traveling job and be ready to scan. So if you join within the next 48 hours, you will get founding members price plus a one-on-one coaching session with me and a free access to one of the workshops that I will be hosting the rest of this year. So I do that on a quarterly basis. So those are some of the bonuses that you will get if you join within the next 48 hours. After 48 hours, the bonuses will be gone and the price will go up. So if you're interested, there is a link to an application. Make sure you apply, get in this program, okay? I am only taking 10 spots for this first round, so make sure you get in and apply. So let's dive into today's lesson. Let me share my screen. All right. Okay, so the topics for today is what is a CT protocol, an example of a common CT protocol, some scan parameters, contrast, post-processing, and reformats. So typically, I picked a common CT protocol that we typically see every single day we use is a CTA of the chest. Now, of course, those indications can be for PE, which is like the standard norm for dissection, aneurysm, or anything that requires an arterial injection. Centering. Please make sure you guys isocenter properly. Make sure you're centering to that Z-axis of the patient. Your centering is going to be at the sternal notch. Centering is so important because you want those doses to be calculated correctly. Positioning. So supine, feet first, with the patient's arms above their head if they can. Now, of course, if they have fractures, do not do this, okay? And then if the patient is ambulatory and able, because sometimes we get patients who are unconscious, they're altered, have the patient hold their breath when possible to minimize the movement of the heart. Now, your scanning parameters. So we do 2 scouts, PA and lateral, okay, if applicable. Some facilities don't. And then your scan range is going to be the top of your apices to mid L2, so usually to the adrenals. Now, there are some radiologists that do like mid kidney, so make sure you check your exam protocol to make sure you're scanning within those ranges, okay? Then we typically do a helical scan. Your slice thickness is going to be a 2 millimeter contiguous, so it's 2 by 2, so they're not overlapping, okay? They're like right next to each other. And then bolus tracking, usually it's a 5 to 10 second delay before it triggers your scan. Now, bolus tracking or smart prep or sure start. So those are the common names that you typically see depending on what type of scanner you have. So you want to place your ROI, your region of interest, in the pulmonary artery. So your little circle is going to go in the pulmonary artery. Now, let's say you can't really see it. There's a lot of artifact. The patient has had multiple surgeries. There's a bunch of fluid. You can't really tell. You can always place it outside of the image and manually track it. But just remember, you will have to manually set off your scan because when you don't put it in the vessel, it's not going to set off the scan. And then, like I said, it's 5 to 10 seconds after injection to start tracking contrast where it hits 100, 150 Hounsfield units, and then it triggers the scan. But if you don't have that ROI in that artery, you have to manually trigger it, okay? Now, your injection protocol. So 18 to 20 gauge AC or a power injectable line. Normally, we use IsoView 370 or OmniPig 350. Now, VisiPig is used as well, because I know some facilities do use VisiPake for PE studies. VisiPake is very good for patients who are renally compromised, diabetic patients who have kidney issues, because what it does is it highlights what you need and then it starts to exit from the body, where IsoView and OmniPake tend to hang around, especially for those dialysis patients. Now, typically contrast, we inject between 75 to 85 cc's with a 20 cc test injection and a 30 cc saline injection. Now, this will also change if you have a patient that's over 350 pounds. You might have to use a little bit more contrast, a little bit more saline, because their heart doesn't work as good. And then typical rate is 4 to 5 mLs per second. So hence why we need an AC, right? Now, I have two scouts here, two images. So the one on the left, this is your box, exactly where you want to set up your scan, just like this, okay? So mid L2. And then the one on the right, that is your bolus tracking, your smart prep. So you want it right at the level of the carina, where that's where your pulmonary artery is going to be when you track contrast. And then this is a nice slice right here. Nice picture of the pulmonary arteries, nice and highlighted. Of course, on this exam, there is no PE. So this is exactly what you want as far as contrast enhancement. So this is actually a pretty decent PE study. Maybe could have gone a little bit sooner because you're starting to see like the aorta highlight a little bit. So maybe a little bit sooner, but we're not going to be big on critiquing, okay? And then your reformats and post-processing. So your axials are soft tissue, 2 millimeters, long at 5. Some radiologists like 2, so it just depends on your facility. Coronal and sagittal MPR, so soft tissues at 2 millimeters. Coronal and sagittal MIPS, so this is your maximum intensity projection. So it's a 2 by 10 millimeter slab, so they're really thick, okay? And then if you're doing a CTA of the chest, not for PE, but for dissection or for AAA or thoracic aneurysm, you want to do a VR, so a 3D of the vessel, and 20 images rotated is usually pretty good. All right, so I'm going to stop sharing my screen because that is what I have for you today. So I want to thank you for joining me on these 3 days. I do apologize that I did have to pre-record considering I've had a death in the family. So if you have any questions on any of the information that I've taught over the last 3 days, please don't hesitate to ask in the Facebook group. I will go ahead and answer all your questions as soon as possible. The PDF guides that I have provided, they will be available to you. And if you're interested in joining the CT Educator Coaching and Mentoring Program, make sure you fill out the application. If you go ahead and sign up to the program within the next 48 hours, you will get founding members pricing and the bonuses that I explained. So a one-on-one coaching session with me and a free access pass to one of my workshops. So get on all the action, okay? Thank you so much once again for joining me in this live event. Have a good day.